I'd now like to welcome Anne Kilty from Oxford, who has done a lot of work on radiation therapy for bladder cancer. Of course, radiation is even less invasive than robotic surgery, so incredibly successful. But do we need a credible biomarker to make it even better? Thank you, Anne.
Thank you very much. I'd like to thank the organisers for inviting me today. Yes, so we're talking about biomarkers here in muscle-invasive bladder cancer. So why would we actually need a biomarker? So as we all know, we can either treat patients, if they're fit enough, with neoadjuvant cisplatin-based chemotherapy, and that can be followed by either cystectomy or multimodality bladder preservation, which is essentially a radiotherapy-based treatment. So you would ask for a maximum TURBT, followed by radiotherapy, probably with concurrent chemotherapy if the patient's fit enough for it. Unfortunately, there's no randomised trial data after this Bayer trial was unsuccessful, and I think Robert will talk about that a bit. But these are data that we have from Leeds, and these are all comers from 1996 to 2000 that either came through the front door and had a cystectomy or radical radiotherapy without chemotherapy. And as you can see, the curves for cause-specific survival are non-significantly different. I would hesitate to point out that the top curve is actually the radiotherapy curve, but it is not significantly different from the cystectomy curve. But this begs the question, if we can add chemotherapy to the radiotherapy, would the survival from chemoradiotherapy be even better than cystectomy, which is obviously a bit controversial with this audience. But at the moment, patients can choose between the two treatments, either cystectomy-based or radiotherapy-based, and it's often a difficult choice for patients to decide whether they're going to lose their bladder or whether they're going to retain their bladder but have to have the intensive follow-up with check cystoscopies and potentially a salvage cystectomy, which is technically more difficult. And if you had a reliable biomarker, this could help aid the patient decision-making. This is just our series from Oxford, from our joint clinic. We've had over 100 patients in the last 5 years that have come and been suitable for either cystectomy or radiotherapy, and they've had their treatment. And what you can see here is that the red are the cystectomy patients and the blue are the radiotherapy patients. Over the age of 80, we've had very few cystectomies, I think only 2 here. And under the age of 65, we haven't given any radiotherapy. Currently in Oxford, we're still only giving radiotherapy only, but with obviously the NICE guidelines, we're now getting our business plan together to give chemoradiation. So there may be that some younger patients will opt to have that option. But between the ages of 65 and 80, when we've given the patients choice, actually half of them have had radiotherapy and half have had surgery. And it actually comprises 47% of all the patients is in that age group. So we've been looking at a protein called MR11 as a biomarker, and this is involved in the DNA damage repair process, which is important for outcome following radiotherapy. And so we had 2 cohorts from Leeds, where we had radiotherapy treating from 1996 to 2000 and 2002 to 2006. There were about approximately 90 patients in each group. And we also took a matched cystectomy series from the same time in Leeds. And what you can see when you combine the radiotherapy data is that those patients whose TURBT specimen had high expression of the MR11 on immunohistochemistry had a much better outcome than those with low MR11 expression. So it went from 70% 3-year cause-specific survival down to 43%. But when we looked at our cystectomy series, there was no significant difference between the 2 arms, and if anything, it was the other way around. This was showing us that it's not a prognostic biomarker, but it's predictive of radiotherapy outcome. And the interesting thing about this result, it was counterintuitive in terms of DNA repair, because you would expect a DNA repair enzyme, if it was high expression, that would repair the DNA, and therefore the radiotherapy would be less effective. And in fact, in the lab, we're now looking to see why this is so, and we think we may have come up with some answers. But even though this was a contradictory result, we were delighted to see that a series from Denmark and Germany, where they looked at their chemoradiation patients here, in this case, and their cystectomy patients actually replicated our data. So this suggests that the data are indeed promising. So we managed to get funding from Cancer Research UK in their bid biomarkers imaging development and discovery group that gave us the funding for our trial called the MOBA-BLOT study. Not a particularly great acronym, but it was to look at outcome prediction biomarkers in bladder cancer after radiotherapy. And our aims were to further develop this MR11 immunohistochemistry assay as a predictive biomarker in radiotherapy outcome. And we had a number of things that we had to go through. So we had to streamline the staining protocol. I'm not going to discuss today, but comparing manual scoring methods with automated scoring, and then to compare the performance across 3 main centres, and that was Oxford, Manchester and Birmingham. And then the idea was to develop a testing algorithm to look at this method in a prospective analysis. So we needed to validate the MR11 finding, and this was looking at tissue from the BCON and BC 2001, large randomised studies in bladder cancer radiotherapy, and also using 200 patients from the Manchester cystectomy series as controls. And then ultimately our aim was to progress the assay further by developing a nomogram. So this is the staining. In terms of streamlining the staining protocol, we developed our staining protocol and then tested it across the centres. So for the BCON data, we compared Oxford and Manchester, and then for the BC 2001, we compared Oxford and Birmingham. And as you can see here, we've got very reproducible staining on our Leica Bond machines, which we happen to have the same machine in all 3 centres, and we feel that the staining is extremely reliable and extremely robust across the centres. So here we have a problem that arose with the BCON study, was that somebody had already been into the blocks and taken 1 millimetre tissue microarray cores from them. 1 millimetre tissue microarray cores are actually huge, and as you can see here, our pathologist had outlined the areas of invasive bladder cancer, the green circles here, and what you can see is that within these areas somebody had taken multiple cores from each of these areas, so much so as it kind of rendered the tissue not very helpful in this study. And this contrasts with the BC 2001 series, where they hadn't actually taken any TMA cores, and as you can see here, we've got lots of nice areas that we can assess for immunohistochemistry of MR11. So that was a major problem with the BCON series. Fortunately, there are TMAs made from these cores that we're going to start looking at. So having got the staining standardised, we then had to look at scoring methods, and so we did this across Manchester and Oxford. Within each centre we had 3 people doing the scoring, so it was looking at semi-quantitative score, which was the product of a percentage positivity, which initially was actually counted by one of the people in the lab, but then subsequently we developed a guesstimate scoring system where we used PowerPoint presentations to show what 40% positivity looked like, what 90% positivity looked like, and got people to estimate the percentage positivity. And this was a product of that against the intensity scoring from 0 to 3. So 0, 1 plus, 2 plus, 3 plus. So the total score could be 300. And as you can see here, we tried to reach a consensus in both tissue that had actually been stained up from Oxford, and then others which had been stained up by Manchester, and photos were taken. And as you can see, we didn't always totally manage to reach a consensus. In this one, we were quite similar to begin with. There were 3 of the 20 that weren't the same, but we managed to reach a consensus in all but 1. And in this, we failed to reach a consensus on 3 of them. So we looked at the BCON data, and here we have just the consort plot here. Because of the problems with the cores, we were down to 112 cases at the end of this, having started with 333. So that was disappointing. I'd apologise for the quality of these. Our statistician has gone on maternity leave, so I would have liked to have had beautiful slides like Noel's, but unfortunately this is what I've got. And the take-home message here is it was a very disappointing result in that the data had completely flatlined when splitting it into quartiles, unlike our original series, which were done with manual MR11 staining. So this was the same for both Manchester and Oxford. We wondered whether part of this was because of these big cores. We didn't have much tissue to work with. But what you can see is that the median semi-quantitative scores, and this is out of a total of 300, were 194 and 196, with the 25th centile being at 179. And I'll come back to that in a minute. As I say, we thought the problems with the BCON were going to be because of these big cores having been taken out, but we were very disappointed to see that BC 2001 gave another flatlined result as well. So Here again, the median SQS was 194 and the median 25th centile was 190. So we had to really do a bit of head scratching to work out what was going on. So when we look at the comparison, as I say, we felt that our staining was very good and comparable between centres. But in the meantime, we'd also got leads to stain up 50 sections with the view to trying to get their pathologists to actually do a more Gestalt-type scoring system that would be quicker and potentially more realistic in the NHS setting. And they didn't have a Leica Bond machine. They had a Daco autostainer. And what we found here was that their staining was different from the Bond machine, and that there seemed to be a greater dynamic range, and the staining was, if anything, less intense. And so therefore we wondered whether that was actually what our problem was from our original work, that actually the semi-quantitative score, median and 25th centile were too high, and maybe the staining was too strong. So then we went back and looked at our controlled tissue microarrays here, and as you can see, the Oxford, all of it's a bit brown. But when we looked at the Leeds ones, there are actual cores which are particularly negative and some that are less strongly stained. And this is the kidney outline, which there was certainly less background. So what we came to the conclusion was that maybe the staining had not been optimal. And we have looked into detail as to what's the differences between the machines. And we wonder whether actually the Bond Max machine, the epitope antigen retrieval, is actually the problem. And we're now actually working on this at the moment. And here's our latest staining. This is still not perfect, but we're getting there. So I think that we could agree that that's more similar to that than to that. So we're developing the staining and improving it with the idea of going back and looking at the TMAs from Beacon and then the BC 2001. So just to summarise, the question was, do we have a credible biomarker? Well, I think we've shown that we can... in the original work with MR11 manual staining, we did have correlation with outcome, and there were two series from Leeds, and then there was an independent validation from Denmark and Germany. However, with the automated scoring, there's currently no correlation with outcome, but we are modifying our staining system, and we will repeat with optimized staining. So to answer the question, not yet, but we're still making progress. I've been asked to plug this meeting at Oxford in September, the EURO meeting in the Mathematical Institute, and I'd just like to thank the people that did the work. So we've got Alexa Walker, DPhil student, Kathleen Karashki, who is the MR11 technician, and Sean McGill, who is a final honours school undergraduate. Thanks very much.
Thank you, Anne.